more common in people with severe epilepsy. And in chronic epilepsy, it's 20 to 25%. While they found, when they studied in a high group of patients, large group, that even seizure-free patients with epilepsy, yes, they have lower rates than people who are intractable to treatment, but still they have higher rates than the general population. Even it's reported in people who were recently, they were seizure-free. And I did put a question mark, because we always talk about the forced normalization and the effect of it. Is it still there? It's possible. And we discussed that issue in the Congress. Yes, because we don't know everything about it. It could be part of this complex relationship between the psychotic morbidity and the epileptic activity. Actually, one of the amazing things that they reported, two things I would like to share with you. One, there's a medication now they are using. It works not on the stopping the epileptic seizure. It works on preventing the epileptogenesis. It prevents the seizure to stop. This is a revolution in treatment. And the second thing, now they are using highly sophisticated radio imaging techniques. So they can pinpoint the focus with an error not more than 1 millimeter. So they say this is the focus. And the third thing, now they are using, you know, the gamma knife and whatever, these are the things they are old by now. They are all using different methods to treat this focus without any damage to the brain. They are using highly focused, intensive ultrasound. Ultrasound, you put a patient in a helmet, and a special focus of highly focused, sensitive ultrasound will be to that focus and will just put an end to the whole problem. So, so many things are trying to be discovered, and they are working on it. For anti-epileptic medications, I believe you know better than me that the number of anti-epileptic medications have been associated over the decades with some psychiatric problems. But that was found in some studies. Other studies and meta-analysis did not find that. Since 2008, FDA made a warning that all anti-epileptic medications should have a warning to tell that they might increase suicidality rate, and we have to educate the patients about that. A number of anti-epileptic medications are proved to have, evidence-based, especially levetiracetam, phenobarb, topiramate have been associated with some problems. And you know, so many of the anticonvulsants, they have psychotropic effects, carbamazepine, lamotrigine, and valproate. So this raised a controversy. This is the one I found that is more well structured and more sound. I'm not, an author. I'm not a jury to decide about it. But through the tens of papers, I found this is more sound. That was done in the UK. They did review anti-epileptic drug effect, including suicide. They found 3 studies that found that it's overall increase in the risk among people with epilepsy. One study, people with high risk of depression, they have higher rates. One study showed the contrary, that it has protective effect among people with epilepsy. And 2 studies, it's more patients with epilepsy when they have bipolar disorder as a comorbid. And they showed that it has a protective effect on one side and at the same time a psychogenic effect. So they concluded there is no clear evidence of association between anti-epileptic drugs and increased risk of suicide. Still, we need to be always on the alarm side. We have to educate patients since there is a warning and since there are reported cases of increased suicidal ideations. And it might be related to increasing the depressogenic effect of the antipsychotic drug or the psychosis-inducing effect of the drug. Epilepsy surgery was also studied as a factor. Some studies found that patients with epilepsy with temporal lobe resection had higher mortality rate due to suicide. So they did the surgery to control the seizures, and they had higher rates of suicide. This is some studies. Some people continue to have seizures after surgery, and some people will be seizure-free. When they compared the standardized mortality ratio between them, so people who continue to have seizures, they had higher rates, 7.4 compared to 1.7. Another group, they followed people with temporal lobectomy and followed them for a long period of time, 5 to 24 years after surgery. That 7 deaths were reported, 9 of them were due to suicide. When they studied and investigated these people, 5 out of 9 people with epilepsy who completed suicide, they were seizure-free after surgery. So still we don't have the answer 100%. But epilepsy surgery is a real gift you can give to patients. So they are just doing more studies to be sure what are the parameters they need to put under control. I know only one patient here. She's a young Emirati lady. She has been following up with us for the last 3 or 4 years. She has epilepsy with psychosis, and she's very timid. It's a classical, we call it the personality change in epilepsy. She has been following up here for years. And then she started to follow up with her epilepsy with Cleveland Clinic. And last September, not this September, September 2017, she was very excited telling me, Dr. Mufeed, they will do surgery for me. What do you think? I said, go for it. Because they are scientific. If they decide that you need it, go for it. And if you see her now attending the clinic, she's a completely different human being. She's happy. She's smiling. She's confident. She has been seizure-free since September 2017, since the operation. And they are reducing. She was under 4 anti-epileptic medications. Now she's under 2. They are gradually reducing the medications. And psychologically, she is better. We hope sometime we will reduce our also psychotropic medications. So it's something highly promising when it's done in the right place in the scientific center. So the suggestion is that good seizure control after successful surgery does not eliminate the risk of suicide, and we need to keep it in our mind. This will bring me to the recommendations. I will just review a couple of recommendations if you don't mind. So we have high rate of mood disorders, anxiety, and suicide among people with epilepsy. So we need to identify and treat aggressively all psychiatric problems among people with epilepsy if we are looking for better quality of life. Anxiety, depression, and suicidality should be assessed as part of routine follow-up in epilepsy clinics. I try to make it clear to all the audience, please, you are all senior people, but you are missing things. Make it a routine to have the GAD-7 and PHQ-9, and your trained nurse can do it, and they will tell you this score this patient might be. So screening for depression has to be in the first visit and on annual visits. And any case that's screen positive has to have appropriate evaluation. Is it really depressed, or is it just a score, or is, whatever exaggeration. If any possible risk factor for suicide, we have to evaluate it among all patients. When we have a positive one, we have to go into details. What are the positive factors? Stress, financial problems, relational problems, wherever. Anxiety, it's common. That's why it has to be screened, and GID-7 is approved, and it's simple. We have to advise the patients about the suicide risk associated with epilepsy and with the medication. Caregivers of people with epilepsy, they need to recognize the mental health problems and to be trained how to respond to it, how to contain the patient, when to recognize that there is something dangerous and we need to work on it. Physicians, they should be more aware of the risk of accidental and intentional medication poisoning We don't give them tricyclics. People with epilepsy, if they have depression, never give them tricyclics because they might commit suicide. We give them safer medication. Healthcare providers and caregivers, both of them, we need to be aware of the harmful substances in the environment of the patient with epilepsy and keep it away from them. And patients should be warned about this accidental poisoning and advised about prevention. And these are a couple of questions that I raised to the audience. So when you say psychiatric morbidity is high among people with epilepsy, are we talking about shared pathophysiology? Is it related to the comorbidity? Or it is because epilepsy on one side and psychiatric comorbidity, both of them, they have psychosocial negative impact on the quality of life. Early onset of epilepsy, is it related to the pathogenesis because the brain is developing, or it's related to having more chronic disorder, or it's related to having difficult to treat, or because of the major psychosocial impacts? When we say higher rates among people with temporal lobe epilepsy, are we talking about the disorder because it's more difficult to control, or because of the psychopathology is similar? And for anti-epileptic medications, are they protective or psychogenic? So we need more studies and we need more research. The last recommendation is that our basic science, epidemiology, clinical research, all need to explore this gray area where neurology and psychiatry meet, especially when we talk about epilepsy. And we need to recognize the gaps in our healthcare and research, and we work diligently to close them. Allow me a few minutes, I've finished my presentation, just to share you something that was highly nostalgic. Among the audience, we had Professor Simon Shortman. Professor Simon Shortman, he's a professor of neurology, senior consultant in the National Hospital for Neurology and Neurosurgery. When we started our chapter in Iraq back in 1999, no physician would graduate from internal medicine, board, neurology, psychiatry, unless he studies epilepsy well. And to study epilepsy well, you have to pass by one of the books that are written by Professor Raoof. He's a figure, he's an author, he's a reference, and he's a historian. So for me it was a dream to see Professor Raoof, because when I did my PhD in the 1990s, I used his papers and his textbook. And in our chapter, he had one textbook at that time called Epileptic Classification of Epileptic Seizures and Syndromes. It was mandatory in our chapter. Every week, one of the doctors would prepare one of the chapters and we discuss it together on a weekly basis, so that within 6 months, we have completed that textbook at that time. So he was there. And I went through the internet to see how many books this gentleman had. And I did write as a single author or as a co-author. And I was surprised. This is a review between 2004 and 2018. This is 2004, Handbook of Epilepsy, Epilepsy, Status Epilepticus, Neurology, the International League, 100 years of review, treatment of epilepsy, the epilepsies, Oxford Neurology Library, epilepsy treatment, the beginning of the end of the falling sickness, that's epilepsy, 2012, epilepsy and epileptic seizures, treatment of epilepsy, physicians at war, Queen Square, neurology and epilepsy, a global approach to epilepsy, and this is the last book, 2018, 500 Years of the Royal College of Physicians. And surprisingly, he dedicated one of his books to the Congress. And they did a raffle by the end of the conference. The first time happens to me. I never won a raffle, and I won a raffle. It was my number. This is Professor Raoof, and this is the textbook I won, The End of Epilepsy, He's talking about the last 150 years, how epilepsy started, and where are we now? And he is asking a question. Is it the end of epilepsy? We hope that it would be. Paul Simon, that's the last slide, in a strange emotional status, mentioned that hiding in my rock, I am an island, and a rock feels no pain, and an island never cries. Thank you.